Good afternoon, everyone. We're going to go ahead and get started. This is a Senate Committee on Health. We're going to do an oversight hearing in examining provider moratoriums and fee-for-service for Medi-Cal. Today's Wednesday, February 18th. It is about 1:40 in the afternoon. Just background, last year, Senator Walters, before she went to Congress, introduced SB 1212, which was going to address a concern of a constituent she had in her district with regard to trying to get as a fee-for-service Medi-Cal provider as a lab. My commitment to her at that time was I thought we needed to look at this a little bit further, perhaps have a hearing. That's the reason why we're here today. Unfortunately, she's in Congress, but fortunately for her, she's got elected. But nonetheless, it was still my commitment to her to gather this information. There's a lot of policy questions that I have with regard to the three areas that we're going to be dealing with. That's the clinical laboratories statewide, the moratorium, the durable medical goods providers located in Los Angeles, Orange County, Riverside, San Bernardino counties, and out of state, and the non-chain, non-pharmacist-owned pharmacies in Los Angeles County. So, I have some questions and concerns, but I'm going to be listening to all the speakers as well as testimony from the Department of Healthcare Services. An announcement, Jennifer Kent, Department of Healthcare Services, will not be here today. It's my understanding that Karen Johnson will be here, who was originally on the agenda, but will also be speaking and staying on the agenda, the Chief Deputy Director, Policy and Program Support from the Department of Healthcare Services. So with that, I'd like to extend any comments that the Vice Chair, if she has any to make. Otherwise, we'll get started.
Just real quick, Mr. Chairman, thank you. I just want to take this opportunity again to thank you for holding this hearing and to fulfill your commitment with our former colleague, Senator Mimi Walters. As its core, the provider moratorium issue touches on several areas that I care deeply about. One, ensuring Medi-Cal beneficiaries have a robust network of providers. Two, protecting taxpayers' dollars by rooting out fraud from public programs, and also maximizing opportunities for California businesses. So I'm very excited this is the next step in improving upon those status quo, and I look forward to the testimony. And again, thank you for the opportunity.
Thank you. One more announcement. We have Tanya Hammond, who will also be testifying for DHCS. So with that, we're going to go on to item number 2, overview of the fee-for-service Medi-Cal provider moratorium. Well, if we can have the department come up and go ahead and get started. Good afternoon and welcome. So I'm going to have to call Jennifer and ask her why she didn't show up.
Scheduling conflicts. So thank you, Mr. Chairman and members of the committee. I'm Karen Johnson, Chief Deputy Director, Department of Healthcare Services. With me today is also Chief over Provider Enrollment Division, Tanya Hammond. So starting with an overview of the existing law, it was in July of 1999 that Welfare and Institutions Code Section 14043 was chaptered into state law and authorized DHCS, Department of Healthcare Services, to impose enrollment moratoriums on specified Medi-Cal provider types when necessary to safeguard public funds and to maintain fiscal integrity over the program. In order to deter fraud and safeguard public funds and the fee-for-service side of the Medi-Cal program, the healthcare services implemented moratoriums on service categories that have historically high levels of fraud. So in the Provider Enrollment Division, they process and enroll 40 different provider types. Of those 40 provider types, there are only 3 under current moratorium. And the 3, as you mentioned, are clinical laboratories, which are statewide, and then the durable medical equipment providers located in Los Angeles, Orange, San Bernardino, and Riverside counties, and pharmacies located in Los Angeles counties that are non-pharmacist-owned and non-chained pharmacies. Over time, these provider moratoriums have proven to be flexible Medi-Cal program safeguard tools for our department The moratorium not only limits the number of providers and service in these categories so that we can properly track and manage and monitor the services that are being provided. We've also been able to monitor and, if necessary, be able to expand and create exemptions to the moratoriums to address beneficiary care needs. And also, when there's been healthcare industry changes, have warranted adding additional exemptions. Continuation of the moratorium will protect and maintain the progress made in the department's anti-fraud initiatives. So beginning in October of 1999, the department imposed its first enrollment moratorium on durable medical equipment providers. It was a 60-minute show, knee-deep in fraud, that highlighted problems, uncovered fraudulent billing by enrolled Medi-Cal providers. The California State Controller had estimated $1 to $2 billion annually was being fraudulently billed. Fighting fraud quickly became a top priority for the department and the administration. In 2003, the Bureau of State Audits, the LAO, and the Office of Attorney General recommended that the department adopt an assessment and planning model tool. As such, we began preparing the Medical Payment Error Study report, which was issued on an annual basis, and now it's biannual, where it identifies the areas of greatest risk for payment errors and establish how to best allocate and direct those resources. In addition to IMPAS, our IMPAS report, Medical Payment Error Study, DHCS, our department, uses different assessment processes, utilizes information gathered from random claim reviews on a weekly basis. We conduct targeted reviews. We also do an extensive data mining efforts. We conduct analysis, and from that, we're able to target our resources appropriately. The targeted data reviews are conducted on a specific provider type, and data mining is another tool which, when conducting with the Medical Payment Error Study, is an analytic process designed to explore large amounts of data in search of consistent patterns and trends and relationships between variables, and then to validate the findings and applying those detected patterns to new subsets of data. So periodically, we have providers that come forward to the department to ask us, and they seek an exemption from the moratorium. So these provider associations and individual providers have contacted the department to request modifications to the moratoriums to add exemptions that would allow for more providers to participate in the program and to address issues. The department considers all requests, and in some cases, the requests have resulted in the creation of new exemptions. Our Provider Enrollment Division works closely with our program officials in approving those respective exemptions. So the assessment, as I mentioned, includes individuals from our pharmacy, our laboratory field services at our sister agency, Department of Public Health. We collect their input, determine access of care issues, and we work closely with provider organizations and stakeholders. So with regards to the lab moratoriums, and I want to address each of the three briefly, the goal is to limit the number of providers and to closely monitor these services. As of January 2015, there are 478 independent clinical laboratories currently enrolled in our fee-for-service Medi-Cal program. In addition, there are more than 5,000 physician offices enrolled in the program that are eligible to perform and be reimbursed for provider-performed microscopic procedures and of waived lab tests and exams. In 2014, $136 million was paid in lab claims, and this is on our fee-for-service side. This is a little bit of a change from 2011, which was approximately $230 million. The result of that change can be directly attributed to the shift from shifting our beneficiaries from the fee-for-service into the managed care. Since 2001, DHCS, our department, has continued the moratorium for labs and currently includes 16 exemptions. Our provider enrollment data that we have at the department also shows that the lab moratorium has not hindered many eligible providers from enrolling. In 2014, 74%, or that's 40 out of the 54 of the laboratories that have came forward, received an application and were approved for an exemption. With our durable medical equipment provider moratorium, which has been in place since 1999 as well, we've continually extended, and it currently contains 12 exemptions. This moratorium applies only to DME providers that are located out of state and with 4 counties. When it was first implemented, it was implemented on a statewide basis. Since then, it's been reduced to the 4 counties to address concerns about the durable medical equipment services in less populated counties. And it's remained in place in counties that have had most of the history of fraud in Medi-Cal and Medicare. In 2014, 93 out of the 103 DME applications that we've received, that's approximately 90% from these 4 counties, were able to meet moratorium exemptions and were approved. Currently, there are 719 providers that are enrolled, in which 274 of them, or 38%, are in the impacted moratorium counties. We have paid out $108 million in claims for fiscal year 2013 and 2014, and about $53 million from DME providers in the moratorium impacted counties. Moving to our pharmacy provider moratorium. Since 2002, the pharmacy moratorium has been continually extended in 180-day increments and currently includes 8 exemptions. The moratorium has effectively controlled the enrollment of non-chain, non-pharmacist-owned pharmacies. In 2014, there's 158 out of the 163 pharmacy applications, or approximately 97% of the applications that were received, met a moratorium exemption. So currently, there's over 6,263 pharmacy providers that are enrolled statewide, and there's about $2.9 billion that was paid in claims submitted by pharmacy providers statewide. We believe that the moratorium has been an effective measure of reducing fraud in our program. This is evidence in comparison to our medical payment error study report. The 2011 emphasized about roughly 6% has been identified as fraud, waste, and abuse. Of that amount, only 2% has been characterized as fraud potential, versus in 2005, the percentage was closer to 8%, and with 5% being related to characteristics of potential fraud. So we believe that this has been an effective measure, moratorium, to address program integrity issues and has allowed us to closely monitor those provider types in our program. And with that, I'm more than happy to take your questions, and we're available to answer, both Tanya and myself. Thank you.
Thank you. Any questions from any of the members? I have a couple questions. I mean, obviously in your opening statement, you had mentioned that there was certain areas that had a higher incidence of fraud, and I'm assuming from that information you gathered that you determined it was these 3 entities. Is that correct?
It initially started with a durable medical equipment suppliers, and there was a 60-minute show that indicated potential fraudulent billing. But there was also a study that was done by the State Controller's Office where they did go with boots on the ground and where they identified that there was a significant number of DME suppliers that were not operating at the place of business. Immediately, there was about 10% of the providers that were shut down immediately based upon that field review. Since then, there was allocation of resources that were provided to the department, and then it was from that we conducted individual studies. There was also, I want to say back in 2005, 2006, there was a pharmacy outreach project that we completed at the department that also identified lack of medical necessity issues and coding errors, which presented some problems. But it was a couple of things that were raised to our attention, and that's why we considered certain provider types to be higher levels of fraud. And with the medical payment error study report that we do on an annual basis, it identifies those areas of concern.
Okay, so it's, of those three, you're saying, or you think it's the durable medical goods equipment that had the highest fraud, and then from your presentation, you're claiming or feel that because of the moratorium, it's kept that at a bay?
That is correct.
Okay.
So it's been an effective tool. The Provider Enrollment Division is the first line of defense on program integrity issues. The pay and chase model is rather costly in terms of resources, and it does require, significant amount of resources, to go out to perform the field reviews. And so really evaluating and conducting the screening on the front end as part of our front end controls in protecting the Medi-Cal program.
Okay, and I can understand the importance of making sure that there's no fraud or abuse and catching any entity that is overbilling or inappropriately billing, but how would you answer for those entities that are doing business the appropriate way, who want to do business with the state of California? Because of the moratorium, it makes it more difficult. Where is that checks and balance to allow good actors to be part of the system other than the exemptions, and where is the 16, the 12, and the 8? So I guess my question is just, there's got to be a mechanism for allow them to be able to do business in the state of California.
Sure. And I'll probably ask Tanya to kind of expand, but each of the moratoriums we do look at every 6 months. So we're constantly evaluating, we're looking at access to care issues, we are listening to stakeholders, and listen to associations, and then based upon that feedback, we are making adjustments. So when we first initiated the durable medical equipment moratorium, it was on a statewide basis. From that, we've kind of stepped back, and now it's just centered on the 4 counties. So there has been changes. And I don't know if there's additional things that you would like to add, Tanya, in terms of your constant review and discussion and dialogue with program.
Okay.
Thank you, Mr. Chair and members. Tanya Hamann with Provider Enrollment Division. I guess the only thing I would add to that is that we are truly committed to making sure that the beneficiaries have their access. And the provider enrollment process is not one of individual character, but rather meeting the program requirements, and that's really where we focus. And with the moratoriums in place, it's about ensuring that there is sufficient access and providing quality care to our beneficiaries. One other thing that I would like to mention is the Affordable Care Act and the new program integrity provisions that the Affordable Care Act brought about, putting program integrity at the front end as well. And one of the things that the Affordable Care Act brought forward is they took literally from California's experience our moratorium, and they've implemented federal moratoriums very like California's 188 review, 80-day review. And they've also allowed states to do their own state-imposed moratoriums, as California has done, of course, with informing the federal government every 6 months, which we have done.
Okay. So one last question, and then we'll move on to the next panel. 70% of the enrollment is obviously Medi-Cal managed care, and I believe you said it was 30% is the fee-for-service. This is only dealing with fee-for-service issues.
That is correct.
How do we address and how do we know that fraud isn't occurring on the Medi-Cal managed care portion with our in our codes or various two-plan healthcare systems out there. I mean, is there a mechanism in there to make sure that we're doing the exact same thing and that there isn't any fraud or abuse going on within any of these areas?
Well, certainly, that's always a concern with DHCS, whether it's fee-for-service or managed care. But in the managed care environment, the plan assumes the full risk. And that also includes making sure that they do their proper certification of providers and that there's no fraud, waste, or abuse. But given that they are at full risk, the responsibility and cost of any such fraud would be borne by them.
No, I understand that they're at full risk, but also, let's say they're at full risk and there's significant fraud, they're going to absorb it, but then they're going to build it into their rates the next year round, and that we ultimately, the state of California, is going to end up paying for it. So, I mean, they're going to need to have some metrics to be able to do what you do in the fee-for-service to make sure that we're not taking advantage of or abusing that part as well. And I guess I have another question I just thought of. So let's say somebody's not eligible for, you know, your fee-for-service, those same entities, I'm assuming they can do business within the Medi-Cal managed care portion as well. Is that correct?
That is correct.
Okay.
With the exception of those that are on suspended or ineligible. And
Because
are-
of potential or
Because they're not
investigation or?
Well, it's either the federal government has determined that they're not able to participate in a federal government program, and now if they've been excluded from participating in another state, we also need to exclude them from our program.
Okay, all right. Thank you very much. We'll move on to the next,
Fee-for-service.
we will move on to the next panel, provider perspective on Medi-Cal, and we'll have you guys come back up to answer some questions again. Thank you very much. We'll ask everyone to come up, and we will ask Laura Panos, MS, Director of Genetic Specialists, Amber Genetics, Marilyn Jones, MD, Professor of Clinical Pediatrics, Jennifer Friedman, MD, Clinical Professor of Neuroscience and Pediatrics, Randy Hugh, Health Plan Account Executive Counsel, okay. Robert Ackerman, Advocacy and Management Group Incorporated. We'll have everyone in that order. We'll have those individuals present. Is there a time limit for each one? How much time for each? About 6 each. 6 minutes. And we're going to ask everyone to keep their comments to 6 minutes or below or less. We'll let everyone present, and then what we will do is we'll open up to any questions, any members. So we'll first start off with Laura Panos. Welcome.
Good afternoon. Thank you so much for having me. Good afternoon. Thank you so much for having me. My name is Laura Panos. I'm a certified genetic counselor and the director of genetic specialists for Ambry Genetics. Ambry Genetics is a diagnostic laboratory based in Orange County, California, and we were founded in 1999. For about 15 years, we sought to get Medi-Cal contracting with our laboratory. We're a California company founded by Californians in the state, and we pride ourselves on providing those services. And unfortunately, we were unable to do so actually until last week. Last week, we met an exemption on the moratorium, and we were able to contract with Medi-Cal. However, we do believe that it inhibited our ability to provide services to the state of California, and we do still feel strongly that the moratorium should be lifted to allow for free and fair competition with laboratories with the state. So I have 3 main reasons why I think that the moratorium could be limiting patient access. And the first is innovation. So we're in the diagnostic genetic business, and most of our tests are unique. We use a certain technology now called next generation sequencing, and when you compare that to some older technologies that many of the labs that are currently contracted with Medi-Cal use, Sanger sequencing, there's clear pros and cons, and a provider would do service to their patient by being able to select which methodology is most appropriate for their testing. An example I'll give you is a syndrome called Lynch syndrome, which causes inherited colorectal and uterine cancers. Many labs offer this test. However, almost every single laboratory's assay is different and has different limitations. We are one of the only laboratories in the entire country who offer a specific inversion in MSH2, which is a fairly common mutation that was recently described. Without contracting with us and using our laboratory services, any patient in the state of California with this disease, specifically this mutation, could have an inconclusive result. And their testing through other laboratories would be a false negative, if you will. So we believe that a physician or a genetic counselor who's seeing a patient should be able to select a laboratory based on the known limitations of a specific assay. And just because one laboratory offers Lynch syndrome testing by no means equals the fact that all of these tests are the same. Another reason is data sharing. We believe strongly at Ambry that public dollars, taxpayer money, should go back to taxpayers whenever possible. There are many laboratories, especially in our industry, that don't share data. And the data I'm referring to is in variant classification and how to interpret alterations within our DNA. Additionally, this data could be used for treatment decisions, precision medicine, as Obama has spoken about recently in his State of the Union address. If a laboratory is taking Medi-Cal dollars to perform testing on patients and then not sharing data that could save lives of not only Californians, but anyone at risk to develop these diseases, I don't think that is necessarily the lab we would choose to partner with. And finally, the issue of cost. So if we're spending California taxpayer dollars and we're sending them out of state, we are unable to keep costs in-house. We are a California company, as I mentioned, and we have been able to more than double the amount of California-based jobs in the last year and a half, and we have plans to hire about 200 more California-based positions in the course of 2015. By being able to contract with Medi-Cal, that would only increase our ability to hire additional employees, and we would assume other California-based laboratories who would like to contract with Medi-Cal would be able to do the same. I do think that there are important components to the moratorium, and preventing fraud is certainly important. However, I think there are many other ways to do that. Laboratories are regulated by CLIA, they're accredited by CAP, there's a California state license, and then it's a competitive market. So if a laboratory were to be fraudulent, they would not succeed in this environment. For all of those reasons, I request that you consider lifting the moratorium.
Thank you very much. Move on to the second speaker, Dr. Jones.
Yes, thank you, Senator Hernandez and members of the committee for holding a hearing on what is a very important topic. By way of introducing myself, I'm a practicing clinical geneticist who has been at Rady Children's Hospital in San Diego for 36 years. I direct the Birth Defects and Genetics program there. I'm a professor at the University of California, San Diego, and have served nationally, among other things, as president of the American College of Medical Genetics and Genomics, although I'm speaking to you today as a doctor in California. I have a long relationship with the state of California in genetics, serving as a consultant to the former genetic disease branch and the current genetic disease screening program in many capacities. And I very much want the state to get this right and to lead in the area of genetic testing of its citizens, as it has done so many times in the past. We're here, Dr. Friedman and I, to share our perspective as providers dealing with the effects of the moratorium on our patients and to urge you to lift the moratorium on clinical laboratories. The moratorium is one of several issues that limits access for our patients. Probably first and foremost among them is the low rates that Medi-Cal pays for tests, which discourages laboratories from wanting to provide these services to the populations, and also from hospitals from allowing clinicians to send them. Second are some outdated policies on the interpretation of what is medically necessary. However, if there is a moratorium and you can't even get to the laboratory, that's the place we need to start. We're responsible for the care of these vulnerable kids, and in order to make fully informed decisions about diagnoses and planned treatments when treatments are available, clinicians must have access to a wide range of diagnostic tests. For Medi-Cal, metabolic and genetic tests are often difficult to obtain, in part because the current moratorium creates a substantial barrier to the most cost-effective testing, and in part because many of these conditions are rare disorders, and in some cases, ultra-rare disorders, where there may be only one laboratory in the United States that offers testing for the condition. And if that laboratory is not a Medi-Cal-approved laboratory, there are no options for the patient. Sometimes there are several laboratories that offer a variety of price points, but the better test and the more cost-effective test is not offered by the non-Medi-Cal laboratory. In the laboratory enrollment application, it's a lengthy and onerous process which discourages labs from applying for the exemption and leads to a shortage of options. So I would like to tell you about a family that was directly affected by this. It's a child that I've seen very recently. She's a 13-year-old girl who was the second of 6 kids in a family. She collapsed at school and was admitted to Rady Children's Hospital, where she was found to have a hole in her heart and a problem with the electrical conduction system in her heart, a situation that is called heart block. She was managed with open heart surgery to repair the hole and placement of a pacemaker. This combination of problems is an extraordinarily rare combination of problems. However, there is a very specific genetic condition that causes holes in the heart and heart block to occur together. There is one lab in the country that offers testing for this condition, and it is not a Medi-Cal-approved laboratory. During the course of her hospitalization, we learned that her mother's brother had died of a heart problem, and one of mother's other brothers had an irregular heartbeat. And now this looks like this gene is in the mother's family, and all 5 of this child's siblings are at risk for testing, which we could not do because we had not been able to test the 13-year-old girl to know what to look for in the siblings. While I was trying to arrange philanthropic funds to cover the testing, the older sister in the family collapsed and was brought to Children's Hospital, also with this blockage in her heart. And we are in the process of using the philanthropic funds that I was able to identify to test the other 5 siblings and 5 little cousins on mom's side of the family who are also at risk. Fixing the problem of laboratory access, I think, is critical, and raising the moratorium is one of the ways to do this. Thank you very much for your attention.